Hey guys, I'm going to start chapter 14, which is cardiac output, blood flow, and blood pressure. And we will go over cardiac output, which is equals to heart rate times stroke volume. And cardiac output is regulated by cardiac rate. So we will talk about the regulation of cardiac rate or heart rate. And then we will talk about what are the factors which regulate stroke volume. And we will talk about the Starling law, which is otherwise called Frank-Starling law of the heart. Then extrinsic and intrinsic control of the stroke volume. Stroke volume is influenced by venous return and variables regulating the venous return. Then at the end, we will talk about the hypertension and its complications. So let's go over some terminology first. The cardiac output, which is called is CO, is volume of blood pumped per minute by each ventricle. So the amount of blood pumped by each ventricle in 1 minute is called cardiac output. Next terminology is stroke volume, SV, is equals to blood pumped per beat by each ventricle. So every time ventricle contract, whatever volume of blood is pumped is called stroke volume. Heart rate is the number of beats per minute. So the number of beats in 1 minute. The equation here, CO equals to stroke volume times heart rate. That means cardiac output is equals to stroke volume and heart rate. Again, cardiac output is amount of blood pumped in 1 minute. Stroke volume is amount of blood pumped each contraction of the ventricle, and heart rate is how many times your heart beat in 1 minute. Total blood volume is about 5.5 liter. That means every minute our blood, 5.5 liter of blood is pumped all over your body. So I will go over each component of cardiac output, which is heart rate and the stroke volume, and what are the factors which regulate those the factors. So regulation of cardiac rate. Cardiac rate is rate of heart per minute, and without neuronal influence, SA node will drive the heart at a rate of its spontaneous activity. So if there is no autonomic stimulation on the heart or SA node, then it is only SA node which guide the heart rate. Normally, sympathetic and parasympathetic activity influence heart rate, and that is called chronotropic effect. Okay, so sympathetic is positive chronotropic effect, and parasympathetic is negative chronotropic effect. Positive chronotropic effect means sympathetic increase heart rate, whereas parasympathetic decrease heart rate. Autonomic innervation of SA node is the main controller of heart rate. That means SA node is the pacemaker of heart, and SA node controls your heart at its own rate, but autonomic nervous system can influence it through the sympathetic and parasympathetic nervous systems. Again, sympathetic and parasympathetic nerve fibers modify the rate of spontaneous depolarization in the SA node. Okay. So let's see how sympathetic and parasympathetic stimulation increase and decrease heart rate. Sympathetic stimulation is due to the neurotransmitter norepinephrine and epinephrine, whereas parasympathetic stimulation is due to the release of acetylcholine. So here, We have the control graph here on the top graph, and then it is the middle one is sympathetic nerve effect graph, and the lower graph is parasympathetic nerve effect. So if you see here, this is the pacemaker potential, and then pacemaker potential goes and then once it start, goes to the heart, and then heart produce action potential. Okay. So here, this is the time. Once there is hyperpolarization, and then it opens HCN channel, and then there is depolarization, repolarization, hyperpolarization. Again, the pacemaker potential, depolarization, hyperpolarization. So there are like 2 bits here in control. But when sympathetic stimulation nerve effect starts, sympathetic nerve stimulation release norepinephrine and epinephrine, which stimulates opening of pacemaker HCN, hyperpolarization activated cyclic nucleotide channels. Okay, and this depolarizes SA node faster and increase heart rate. So that means the epinephrine and norepinephrine opens HCN channel more frequently with the epinephrine and norepinephrine, okay, compared to normal SA node function. Whereas acetylcholine promotes opening of potassium channel. So due to the opening of potassium channel, there is resultant potassium outflow, which counters sodium influx and slowing depolarization and decreasing heart rate. So you see here in the lower graph, there is like slowing of the HCN channel, and that's why there is less depolarization, or it takes longer time for the next the action potential. That's why there is less heart rate. So in summary, sympathetic increases heart rate by increasing the opening of HCN channel, and the parasympathetic neurotransmitter acetylcholine opens potassium channel, and that slows the depolarization, and that's why there is decreasing in heart rate. Okay. So the SA node is controlled by the cardiac control center found in the medulla oblongata of our brain, which coordinates activity of the autonomic innervation. Okay, sympathetic ending in atria and ventricle can stimulate increased strength of contraction, whereas parasympathetic stimulation decreases heart rate, and sympathetic stimulation increases heart rate. So from the cardiac control center in the medulla oblongata, it controls SA node, and so sympathetic stimulation increases the heart rate and increases the force of contraction of your heart, whereas parasympathetic nervous system stimulation decreases the heart rate. So here is the summary of the cardiac center stimulation and autonomic stimulation and its effect on the heart. So effect of autonomic nerve activity on the heart. Here is the region affected, sympathetic nerve effects, parasympathetic nerve effects, and what are their effects here. So in the SA node, AV node, atrial muscle, ventricular muscle, and their effect. So let's talk about first sympathetic nerve effect. Sympathetic nervous system in SA node, and it increases rate of diastolic depolarization. So during the resting time, it increases the depolarization of the SA node, and that's why it increases cardiac rate, increases heart rate. In AV node, it increases conduction rate, In atrial muscle wall, it increases strength of contraction. And similarly, in the ventricular muscle, the sympathetic nerve stimulation increases strength of contraction, whereas parasympathetic stimulation will decrease rate of diastolic depolarization and so decrease cardiac rate. Uh, it also decreases conduction rate in the AV node, but parasympathetic stimulation has no effect on the atrial or ventricular muscle. So it does not affect the force of contraction of the atria or the ventricles. Okay, so again, if we remember the equation, which is the cardiac output. So if I write here, cardiac output, CO equals SB, means stroke volume, times heart rate or cardiac rate. Okay. So again, cardiac output is amount of blood pumped in 1 minute. Stroke volume is amount of blood pumped in each contraction, and heart rate is beats per minute. Okay. So if we change stroke volume, that will change cardiac output. So let's see, if we keeping heart rate constant, if you increase stroke volume, that will increase cardiac output. And if you have more cardiac output, that means heart is pumping more blood all over the body. Okay. So stroke volume is determined by 3 variables, and they are EDV, which is called end-diastolic volume. EDV is volume of blood in ventricle at the end of diastole. So when the ventricle is relaxing, at the end of relaxation of the ventricle, the amount of blood collected is called end-diastolic volume, EDV. So EDV is volume of blood in the ventricle at the end of diastole. Okay. Total peripheral resistance, TPR, is resistance to blood flow in arteries, which is also called an afterload. So when heart contracts, heart pumps blood against the resistance in your arteries, like aorta, other greater arteries, the resistance arteries. Okay. And that is called total peripheral resistance, which is called afterload too, because afterload is the tension in the wall of blood vessels outside the heart. Contractility is the strength of ventricular contraction, means the strength during the contraction of the ventricle, how forcefully ventricle can contract. So these are the 3 variables which determines stroke volume. Okay, so EDV is workload or preload on heart prior to contraction. So if there is more EDV, that means there will be more expansion of the ventricles, and that will give more load to the wall of the ventricles. And that's why EDV or preload is directly proportional to the preload and contractility. Okay. So if there is more EDV, there will be more preload, and more preload will produce more contraction, forceful contraction. Okay. Strength of contraction varies directly with EDV. That means higher the EDV, stronger the contraction of the ventricle. Whereas total peripheral resistance is also called afterloads, which impedes, which resists the ejection from the ventricle. That's why total peripheral resistance is indirectly proportional to the stroke volume. That means higher the peripheral resistance, lower the ejection fraction. Okay, lower the stroke volume. Ejection fraction is calculated by stroke volume over end-diastolic volume. Normally, ejection fraction is 60%, and that is an useful clinical diagnostic tool. So let's see if somebody has ejection fraction less than 55%, that is considered heart failure. Okay, so ejection fraction is how much blood is pumped out of how much blood was at the end of diastole. So let's see if our heart gets 100 ml and we pump around 70 ml each time we contract. So 70 divided by 100 is like 70%. That means your your ejection fraction is 70%, which is better than the normal. Okay, and ejection fraction is calculated with the echocardiograph. Okay, let's talk about Frank-Starling law of the heart. So a Starling law of the heart is the relationship of the myocardial contraction with the end-diastolic volume and then stroke volume. Okay, so these two individuals, Frank and Starling, established this the function of the heart. So Frank-Starling law of the heart states that strength of ventricular contraction varies directly with EDV, and this is an intrinsic property of myocardium, means cardiac muscle in the heart wall. As EDV, as end-diastolic volume increases, myocardium is stretched more, causing greater contraction and larger stroke volume. So if you see here in this graph, based on the Frank-Starling law, so x-axis is ventricular stroke volume in milliliter, and y-axis is stroke volume in milliliter. Okay, so let's see, this is the control, and this is the like failure, and this is another graph with increased contractility caused by sympathetic nervous stimulation. So if you draw a line, let me draw the line. So if you draw a line, let's see if I draw a line here, straight line. So at this volume, for lower graph, this is the stroke volume. With increasing the sympathetic nervous stimulation, which increase the force of contraction of the ventricles, with the same end-diastolic volume, it will increase tension up to here. If you add more sympathetic nervous stimulation, then you see with maximum stroke volume. So the increased force of contraction is increasing the stroke volume, and force of contraction can be increased by sympathetic stimulation. That's what this graph is showing. Okay. So again, Frank-Starling law of the art says uh, more in diastolic volume, more stretch in the wall of the ventricles, and that will result in more preload, and more preload will increases the force of contraction, which will result in increased stroke volume. So here, uh, if you remember the skeletal muscle, sarcomere is the functional unit of the skeletal muscle, striated muscle, and your cardiac muscle is also striated muscle. So here, let's see, we have three graph here, four basically, A, B, C, D. So in A, you see there is one sarcomere from G disc to G disc, and here myosin and actin. And here actins are overlapping each other. So in A is a state of myocardial sarcomere just before filling. So it is not full. Ventricle is not full yet. That's why the actins are overlapping with each other. They are not interacting with the myosin. When it is full, you see in B, in C, and in D, the actins are interacting with the myosin head. In C, it is fully interacted. In D, it is fully interacted. But if you overstretch, some of the area, some of the myosin will not be interacting. And that's why after certain length, sarcomere will be not increasing more force. Okay. So here in A is a state of myocardial sarcomere just before filling, and that's why here actin overlap, actin myosin interaction are reduced, and contraction would be very weaker here. But in B, C, and D, there is increased interaction of actin and myosin is allowing more force to be developed, because more interaction of actin and myosin, more contraction, forceful contraction. Okay, so here now, heart has its own spontaneous depolarization and contraction, plus extrinsic control of contractility by sympathetic nervous system, which is the part of autonomic nervous system. Okay, so at any given end-diastolic volume, EDV, contraction depends upon level of sympathoadrenal activity. That means sympathetic activity. Norepinephrine and epinephrine produce an increase in heart rate and contraction, which is called positive ionotropic effect, because norepinephrine and epinephrine increase cytosolic calcium. So they increase intracellular calcium in the cardiac muscle cell. And that's why they increase the contraction. Okay, it is due to increased calcium in the sarcomere, that is inside the cytoplasm. So again here, length of muscle as percent of optimum, 100%. So 100% length of any sarcomere. What do you see? This is cardiac muscle without, and you see the tension without epinephrine. This is cardiac muscle with epinephrine. So with the same 90% tension, let's see here. Let me draw again a line. With the same, I'm going to draw a line from the 90%. Sorry, this is not. So. Okay, so with 90% tension, this is the cardiac muscle without epinephrine. So tension is like here. The second is cardiac muscle with epinephrine, which is ionotropic agent, positive ionotropic effect. That means epinephrine and norepinephrine increases uh, intracellular calcium, and that increase the calcium ions in the sarcomere so that the troponin and tropomyosin interact during muscle contraction. So you see, with the same length of muscle in the cardiac muscle, yeah, with the 90%, the tension is increased. A skeletal muscle has better strength of contraction all the time than the cardiac. Okay, so this is the relationship of the skeletal muscle, cardiac muscle, and cardiac muscle with epinephrine. Okay, so as we know, cardiac output is equals to cardiac rate times stroke volume. So there are several variables in our body which affect cardiac rate and stroke volume, and so ultimately affects the cardiac rate. Here you have some broken lines arrow, and some are solid arrows. So solid arrows increase these variables directly, and dotted or broken arrows, it affects inversely. Okay, so parasympathetic nervous stimulation decreases heart rate, whereas sympathetic nerves stimulate cardiac rate. Okay, stroke volume is affected by mean arterial pressure. So if you have a higher mean arterial pressure, higher blood pressure, that means your stroke volume will be reduced. It inversely affects the stroke volume. Whereas, based on the principle of Starling's law, the end-diastolic volume and contraction strength affect stroke volume directly. So if you have higher end-diastolic volume, will result increased straits in the wall of ventricle, and so increase force of contraction and increase stroke volume. Okay. In summary, the stroke volume is directly proportional to the end-diastolic volume or preload, and stroke volume is inversely proportional to total peripheral resistance or afterload. Okay, so end-diastolic volume increase preload, and preloads increases force of contraction. So what are the variables which affect end-diastolic volume? Here, venous return affects end-diastolic volume. Okay, so venous return is the return of blood to the heart via veins and controls end-diastolic volume and thus stroke volume and cardiac output. And they are dependent on blood volume and venous pressure, vasoconstriction caused by sympathetic stimulation and skeletal muscle pump. So in this flow chart, you can see the breathing. When you have inhaling or exhaling, inhaling creates negative intrathoracic pressure, and that returns more venous blood from the body parts through the superior inferior vena cava in the right atrium. That's why more venous return, more end-diastolic volume, and more stroke volume. Whereas the blood volume, higher the blood volume, higher the venous return. But if you have more urine, that will reduce blood volume. Let's see if somebody has diabetes, type 2 diabetes, and peeing a lot. In that case, you lose more water and your blood volume will be low. If you have low protein in your plasma and you have edema, that means your blood volume is going to your turning into your tissue fluid, and that's your blood volume is less. So this increased tissue fluid, increased urine will affect your blood volume inversely. Okay. Sympathetic stimulation. Let's see if you are in like during the excitement or emergency situation, when there is sympathetic nerve stimulation, that will result in vasoconstriction or venoconstriction. When you are exercising, the blood vessel in the skeletal muscle will squeeze and send more blood to the veins, and that will increase venous pressure, and venous pressure ultimately will increase more venous return, and so increase in diastolic volume resulting in increased stroke volume and cardiac output. Okay, and then we're going to talk about the hypertension. So hypertension is blood pressure in excess of normal range of age and gender. So the traditionally blood pressure is, if blood pressure is more than 140 over 90 millimeter of mercury, then we call it hypertension. But new guidelines by American Cardiology Society, American Cardiology Association, AHA, Association, ACA, not ACC, ACA, American Cardiology Association, ACA, and American Heart Association. But these are the new guidelines. According to new guidelines, the hypertension is more than 130 over 80 millimeter of mercury. Okay, so it has dropped the value of blood pressure to be diagnosed as hypertension. So this is like pre-hypertension. Okay, it affects about 20% of adults population in United States of America. Most common type is primary or essential hypertension caused by complex and poorly understood process. So essential hypertension is the hypertension where we don't know the cause. They are usually due to genetic cause or familial, hereditary. Secondary hypertension is caused by known disease process. For example, kidney disease, heart disease, lungs disease, other congenital heart disease. Those are the causes. Okay. So possible cause of secondary hypertension are kidney disease, like kidney disease, renal artery disease, like your renal artery stenosis, polycystic kidney disease, those are the kidney disease, kidney failure, glomerulonephritis, endocrine disorders of the endocrine glands. For example, excess catecholamine. Excess catecholamines means your body is producing a lot of epinephrine and norepinephrine. And there is a tumor called, here I have written, pheochromocytoma. Here in the note, this is the benign tumor of adrenal medulla. So adrenal gland's medullary part contains a tumor called pheochromocytoma that produce a lot of catecholamines, and that cause high blood pressure. This kind of high blood pressure is very serious. Even treatment will not touch it so easily. In that case, you have to remove the tumor. Nervous disorder like increased intracranial pressure, damage to vasomotor center. These nervous system disorder, hydrocephalus, can cause high blood pressure. Cardiovascular disorder like complete heart block or arteriosclerosis of aorta, which is the hardening of your aorta, can also cause the high blood pressure. Okay. So why hypertension is such a dangerous disease? When you control blood pressure within normal with medication, it is not any dangerous. But if you don't control hypertension, then it is multi-systemic disease. It affects most of the organs of your body. Hypertension is usually asymptomatic. That's why we call it silent killer of our body. By the time a doctor find out that you have hypertension, a lot of organs, small blood vessel, kidney, retina, other parts are already damaged. Okay, so patients are often asymptomatic until substantial vascular damage occurs and contributes to atherosclerosis, increased workload of the heart leading to ventricular hypertrophy and congestive heart failure. It often damages several blood vessels, which leads to stroke and cerebral damage. And that's why hypertension is called a silent killer, because it does not produce any symptoms, but it has already damaged your organs. Okay? Thank you, guys.